Hello, and welcome everyone to our Living Well series. You have questions, we have answers. We very much want to thank our sponsors this evening who helped make this possible: Bristol Myers Squibb, Celgene Corporation, Millennium, the Takeda Oncology Company. It's my pleasure to introduce two members of the IMF Nurse Leadership Board who will be your speakers for this evening. Dr. Beth Faiman from the Taussig Cancer Institute at the Cleveland Clinic, and Teresa Miceli, Assistant Professor of Nursing at the William von Liebig Transplant Center at the Mayo Clinic in Rochester, Minnesota. At this time, I'd like to turn it over to your faculty. And so Beth and Teresa.
Thank you,
Great.
Diane.
Thank you so much, Diane, and thanks everybody for joining us this evening, or for those of you on the West Coast this afternoon, I guess, for this call. And Dr. Faiman and I are very pleased to be presenting to you answers to the questions that all of you have presented to us. And I am going to be moving from our introductory screen to slide number 2, and I will try to remember to encourage you to advance the slides as we move ahead, and I will try and keep you up to date on which slide we're looking at from one slide to another. But looking at slide 2, I wanted to give you some background of where this presentation really came from. It was the brainchild of Robin Toohey, who all of you know and love, and is tonight with her daughter Allie at an awards presentation, but otherwise would want to be with us. And she had come to me saying, would you be interested in answering questions to support group leaders and support group members that they have? And so she went to all the support group leaders that are part of the International Myeloma Foundation Network and asked, what questions would you want answered? And really, they came into these common themes. People frequently and continue to have questions about what are the diagnostic tests that are used to establish the diagnosis of myeloma and how people are responding to treatment. How do you understand these test results, and what's a reasonable schedule? Looking at different treatment options, side effects, and how do you manage those side effects. And then there were sort of this hodgepodge of questions about clinical trials and when should you get a second opinion? How do you look at complementary and alternative medicine using different supplements? And really importantly, how can I help the caregiver? So moving on to slide number 3, and Dr. Faiman and I are going to share this conversation. I will look at the first group of questions that people had on diagnostic testing. And some of the key points that had come forward were things like, what are the tests that I need? How do I understand these test results? How do I know if I'm responding? And what does it mean to have aggressive myeloma? So moving down to slide number 4, before we can really talk about what the tests are, I wanted to give some understanding of myeloma overview. What is the myeloma process? And many of you have heard this before, so I won't labor it too much, but getting a good foundation to understand that plasma cells are a normal part of the bone marrow. They're supposed to be there as part of the immune system, as part of protecting you from infection. But for reasons that we don't fully understand, plasma cells in the myeloma disease process become clonal. There's a single clone of an antibody that's being reproduced again and again. And I think of this as like a photocopier gone bad. And what happens is that these myeloma cells take over a large part of the bone marrow and encroach on the healthy growth of the good bone marrow cells. Plus, they release chemicals, and these chemicals cause organ damage to other parts of the body, frequently bone, sometimes kidney function, and overall have a general body effect. So when we look at that, slide number 5, at the tests that we're doing, there's a broad range of tests that we're looking at. First of all, there are many, many vials of blood that are drawn. Part of that is to look at the myeloma specifically. There's specific myeloma tests that we look at. Some of you may be familiar with the M-spike or the free light chains. Those are very common tests that we do. But we're also looking at things like the blood count. Is there an issue with anemia? Does it show that maybe there's poor kidney function? Does it show that the bone marrow function is not doing well because there's too many myeloma cells in there? How are the kidneys doing? So there are a number of the tests that we look at. And for those of you that are familiar with myeloma, we look at things like CRAB criteria, calcium levels, the renal or kidney function, anemia, and then the bone function, or I shouldn't say function, but if there's any damage. We can also look at the urine to see if there's a large light chain component within the urine. And of course, if we are wanting to understand what's going on in the bone marrow, a bone marrow biopsy is really the only way we can do that, to look at the number of plasma cells that are present. When we want to look at how the bones are affected by these chemicals that the myeloma is releasing, we do imaging. The standard of care, the gold standard all along, has been looking at full body x-rays, but quite honestly, the metastatic bone survey is not quite as sensitive as some of the newer imaging techniques that we have available. So some of you may have had PET scans or MRIs, and these are looking for bone lesions and possibly what we call plasmacytomas, or tumors made up of these plasma cells. For those of you that have been participating in clinical trials, there may be some additional tests that are done, maybe looking at heart function or breathing function. And for people that go on to transplant, of course, those are tests that we perform to know if you're ready to go on to the transplant. But the actual schedule of when testing is done and which tests are done is really pretty individual based on where you're at in your diagnosis and treatment process and what kind of treatments you're receiving. And I won't go into the treatment component right now because Dr. Faiman will do that for us in a few slides from now. So let's move on to slide number 6 at this point, where we talk about risk stratification. And that came from the question that somebody had, how do I know if I have aggressive myeloma? Well, I think it's important to first understand we have a lot of data from masses of people looking at survival and response and things of that nature. And we are very good about writing that information down. And as you can see here, we have information from the Mayo Clinic that has provided what we call MSMART, which is a way of trying to stratify the disease process based on genetic material or genetic information, that we can have people that are standard risk, intermediate risk, and high risk based on these molecular markers. We also know that there's a revision or an update to the international staging system that adds some blood tests, things like the lactase dehydrogenase that if it's greater than normal at time of diagnosis may add to that risk component. But what I think is most important, and I've seen this over the years, is that regardless of what we know about myeloma and what books we've written about myeloma, myeloma has not necessarily read that book. And so for somebody to be labeled high risk, it helps us to guide the treatment that those people need. But not everybody responds as the statistics would say. Even in standard risk, I've seen some people that would be considered standard risk and their myeloma acts more aggressively. So it's just a means for us to have a better understanding of the overall myeloma picture in the myeloma community and help to guide therapy. And I'll just invite Dr. Faiman if she has any additional comments to make about risk stratification. Is there anything, Beth, that you would say to this?
So, Teresa, I think these are excellent points, and I love that you point out that the myeloma hasn't necessarily read the book, and so that's kind of a key point. So when people ask me how high or low risk am I, and you just have to point to the information, but it doesn't necessarily mean that they are going to fit these numbers, and it's a range, and just to keep that and take it with a grain of salt.
Great. Thank you for that. So I'm going to move on to slide 7, which is looking at response criteria, because there were some important questions that were asked about what does it mean that if I have a PR or a VGPR, and one thing that you find once you step into the medical community is that we have an alphabet. We just don't really know how to use it in a particular order. And so what happens is we put a lot of these acronyms together. And what we do with the response criteria is really it's just telling us how well is your myeloma responding to the therapy that you're receiving. In short, if the protein level is going down, that means your response is improving. And ultimately, what we want to see is that people get to a complete response, or what we're looking for is minimal residual disease to no detectable disease. And that's something that's happening with some of the newer testing. We call it next generation flow, which is a very sensitive molecular marker looking at if there's any detectable myeloma. But in short, we have people that can have a partial response, meaning at least 50% of the myeloma has been reduced, a very good partial response, 90%, or different levels of a complete response. And so again, as the myeloma protein goes down, we know that people are having an improved response. On slide 8, this is a tool that I developed for my support group, and I just want to have a little shout out to my support group members who are joining me tonight. Thanks for joining. This is a tool that I developed so that we could go through myeloma numbers to help people better understand it. And as you can see in the middle of the page, there is this Y formation that has the heavy chains, and then there are the smaller fragments that we call the light chains. And for each person, they will have some specific combination of this, whether it's an immunoglobulin G level that reflects a kappa light chain. And so these are things that would be your measurable myeloma numbers that you would be watching to see, are they going up or are they going down? And there are many tools available for people to use. And on the next slide, you'll see that the International Myeloma Foundation has multiple available tools at myeloma.org, not only on how to understand myeloma, but understanding your test results. So if you haven't already received those, either through your support group or online, you can go to myeloma.org, and these can be ordered, and they are free of charge. So I do encourage you to access this very important information. So having gone through that information rather briefly, I will then introduce Dr. Beth Faiman to take over some questions related to treatment.
So for treatment-related questions, I think that these arose from the idea that now Teresa did a great overview on what the treatment background is, but how do you decide what to take when? And so the next slide 11 goes into the managing myeloma, the components. So basically, patients are divided into transplant eligibility and ineligibility. So are you younger and fit, and do you desire a transplant? Because transplant is a standard of care in most institutions. So basically, the individual goes on the initial therapy and then goes through a period of consolidation, oftentimes with transplant or oral or IV drugs, and then through a maintenance phase. Throughout that, we want to keep in mind supportive care. Individuals with myeloma are at risk for infection, so we want to give antibiotics as indicated, bone strengtheners to protect the risk of breaking bones, and so on. There's oftentimes antivirals, antibiotic therapy that we typically recommend. Now the next slide on slide 12 discusses the different classes of drugs, and it's nicknamed the Mibs, the Mibs, and the MABs, and others. And the basic take-home point on this slide is there's so many different options. And oftentimes these drugs will be mixed and matched over time. Steroids are definitely the backbone of most anti-myeloma therapies because they just make everything work better. And unfortunately, they do have a lot of side effects, which Teresa will be addressing later on. The drugs are available in oral formulations such as the MIDs, the thalidomide, lenalidomide, and pomalidomide. The injectable agents are the Mibs, the proteasome inhibitors, and then the MABs are the new kids on the block. These drugs are definitely game changers in the myeloma world. Daratumumab, elotuzumab, and others are showing real promise in clinical trials. So as we go on to slide 13, how to decide on treatment. Well, that's a good question. I tend to reinforce that quality of life is just as important in many cases as quantity of life. However, we need to balance the two. Clinical trial participation is always encouraged, especially if you're eligible. You will have access to your own special study nurses, your own team of individuals that will look at your treatment and make sure that you're at the utmost safest that you can be. We also have current results of clinical trials that we take into consideration. It's such a fast and rapid changing landscape. We just came back from the International Myeloma Workshop in Rome, and now we have new clinical trial information coming at the ASH meeting that will be in December. So the statistics are quickly evolving. We also look at previous treatment. How did you respond? So if you start on an injectable Velcade and Revlimid, did it work? Did it not work? And did you have side effects? And always, if you have questions, don't hesitate to consult with a myeloma specialist. And the International Myeloma Foundation has many resources for you as well. Now, the next slide, 14, talks about transplantation in multiple myeloma. The most common type of transplant that's performed in patients with myeloma is an autologous, which is using your own stem cells. There are different phases of the transplantation process, and basically we want to make sure that you are responding to treatment. So, an example, if you're newly diagnosed with multiple myeloma, you'll oftentimes take an induction regimen, which will be either pills or injections, and then once you achieve some sort of a response, remember Teresa went over the response criteria, once you achieve a response, then we will move forward to mobilizing and collecting the stem cells. Eventually, you'll go through a conditioning, which is just before you get your stem cells back, and then day 0 is a stem cell infusion. Many centers will do this while you're hospitalized, but there's a growing trend towards outpatient transplantation in some centers. We typically follow you very, very closely in the post-transplantation phase, and that's kind of the process. The role of tandem transplant is unclear. In the early 2000s especially, there were a lot of studies with transplantation when the individual would get one and then within a few months get a second transplant. And we just don't necessarily do that as much anymore, I should say, because individuals that did very well from the first transplant didn't necessarily need the second transplant. So ongoing clinical studies are going to further define that role. Allogeneic transplant is not necessarily recommended as initial therapy and should be recommended only in the context of a clinical trial. Teresa, I know you're going to start off the next section, and I just wanted to ask you, with all of your experience, how has transplant changed in your hospital since the beginning of when you've been doing transplants in myeloma?
Well, I'll tell you, Beth, and thank you. I have been doing this for just over 24 years now, and so much has changed. A couple of the things that I think come to mind are, one, supportive care. Our antibiotic coverage is so much better now over the last 20 years that people are able to do this process as an outpatient. There seems to be less in the way of mouth sores because we have better preventative medication, so they're not getting viral infections in their mouth. People are coming in with a better response as a result of all these new therapies that you had just talked about. And so, it seems that they're getting a better bang for their buck with this transplant. I continue to get that question of when to do the transplant, and it really goes back to the previous slide when you talk about the quality of life, and sometimes we have to really look at what it means for the individual based on the timing. But still, at this point, upfront transplant remains the standard of care. But as you've already said, the landscape of myeloma care is changing so rapidly. We'll just have to see over time if that holds true. So yes, I could go on for the next hour on transplant alone, but I know we have a limited amount of time. So I'll move on to slide 15 with the side effects. And I'll tell you, I was very pleased to see that these questions are coming up because it tells me people, one, are being proactive, and that over the years, we as nurses have really been trying to focus on the side effect management, and I think we are, hitting that mark for most people. And so there were a lot of questions about steroids, side effects for the bowel, back and bone pain. The one thing that we hadn't previously addressed that did come out of the topics from this query was things related to fatigue and anxiety and stress, and so we'll go over that as well. But moving on to slide 16, we oftentimes think about side effects specifically to the myeloma treatment, but people will be experiencing side effects to the myeloma before they even start treatment. And this slide gives a nice overview of the things that we're looking at with the CRAB criteria, the bone involvement and the pain that can go with it, the anemia and the fatigue that can go with it, and most importantly, how the myeloma reduces your ability to fight infections. And so commonly that's something that people will experience. Repeat pneumonias, zoster or shingles can crop up. And so those are things that we watch very carefully, and important for people to be careful about their exposures to infections. The next two slides I am going to leave with you with your printed copies or online copies of the slides because it would take too long to go through all of this information. But I think importantly to be aware of as you start different combinations of therapy, because rarely are people on individual or solo therapy, they're on combined therapies, that depending on what drugs or medications you're receiving, there can be side effects, a variety of side effects based on the individual drugs and sometimes compounded by the combination of therapies. So slides 17 and 18 are there for your reference. And if you do have specific questions, feel free to write those down so that we can talk about them at the end of this presentation. So moving on to slide 19 on peripheral neuropathy, and this is a question that comes up so frequently, and I know Dr. Faiman has done extended work on ways of working with neuropathy and if there's anything that she can find to intervene on this side effect, because it is such a life-altering side effect to therapy. I think one of the most important things to think about is prevention or managing early symptoms of peripheral neuropathy that can come from either the disease or some of the therapies that we use to treat myeloma. Something as simple as giving Velcade as a subcutaneous or as a belly injection versus as an IV has made a significant difference in the rate of neuropathy that we're seeing. There's some anecdotal things that have been looked at as far as cocoa butter, acupuncture, different things that you can do to help reduce or eliminate the sensations that you can experience from peripheral neuropathy. It is well documented that exercise actually improves neuropathy. If you are experiencing neuropathy where you're having the numbness in your feet, it is important to make sure that your home environment is safe, that you don't have rugs and furniture that you're going to be tripping over. So I just want to point that out to you. Now, if the symptoms of neuropathy are worsening, it's important that you're bringing that forward to your providers because it may be necessary to change treatment. Again, neuropathy is very quality of life altering, and to stay on treatment that can maybe be adjusted with as good a benefit, but it's important to make those adjustments. There's also some prescription medications that can be used, and many of the patients that I know are on this call have already been taking these medications, and hopefully with benefit. Physical therapy may also be something that can be of benefit. I'm going to move on to slide 20, and this is, I know, heartfelt by not only the myeloma survivors, but their caregivers, and that's the side effects, the steroids. Anybody who is starting high-dose dexamethasone needs to know that there are going to be side effects, the mood swings, the insomnia, the eating, the weight gain that can go with it. It is important, and I will stress this, do not stop or adjust your medication dosing without talking with your healthcare provider. Studies have been done looking at can we eliminate dexamethasone from the treatment regimen, and ultimately it was found that it really does play an important role. Maybe not at the highest doses that we've seen in the past, but still it's an important part of the treatment combination. And so to work with that steroid side effect, maybe be creative with how you're taking it. If you're taking it once a week, maybe you take it in the middle of the night when we all get up to go to the bathroom with a little snack, you go back to bed, and some of those longer-lasting side effects are wearing off by the time you want to get to bed the next night. It is important, like I said, to take it with a snack, a little bit of food, because it will irritate your stomach. And there are medications that you can take over-the-counter prescription to help protect the stomach lining. You know, it's like taking a high dose of acetaminophen when you take steroids. It will block a fever. It will mask a fever. And so if you're on steroids and taking it for multiple days, that even a low-grade fever could mean that you have a serious infection going on. one of the key things, especially for people that are borderline or already diabetic, is that steroids will mess with your blood sugars. It's going to cause your blood sugars to go higher. So steroids, although, a challenging drug to take, it is truly an important part of the treatment approach to myeloma. So moving on then to slide 21. Not a lot of people like to talk about their bowel motions, but it is also another important component and a very real side effect to many of the treatments. Diarrhea and constipation can actually be a significant side effect. So I was at a conference for the IMF a few weeks ago, and one of the ladies stopped up afterwards and said, thank you. I didn't realize milk thistle caused diarrhea. I think you've just saved me. And so really take a look at the supplements you're taking, take a look at the medications you're taking. Many of these things, in addition to the myeloma treatment, can cause diarrhea. Let's say you've had a lot of pain and you've been put on some type of pain medicine that caused constipation, so you then went on a medication to loosen up your bowels. Now your pain is gone because you've been treated and you're not having constipation, but you haven't gotten rid of the laxatives. So again, things are changing, always changing. When you're experiencing diarrhea, it may be treatment-related. There can also be bacteria in the bowel, and so it's always important to talk with your provider in the event that we need to check for a particular bacteria called C. difficile or Clostridium difficile in your bowel. Dehydration is a very real part of having diarrhea, and if you're dehydrated, not only do you feel lousy, but your kidneys aren't very happy either. So it's important to stay well hydrated, and if approved by your physician, there's some anti-diarrhea medications that can be helpful as well. So moving on to slide 22, talking about pain. Pain is also one of those very life and quality of life altering symptoms that people have, and it can come from not only neuropathy, but also from bone involvement or bone disease. And I know many people are a little bit leery of starting narcotics like OxyContin or oxycodone or MS-Contin, any of those morphine-based products. But the reality is that pain only serves the purpose to let us know that there's something wrong. And if myeloma has caused compression of your vertebrae, you're going to have pain. And pain doesn't allow you to be active. And so it's best to manage the pain, to allow you to be active. Sometimes it will require surgical intervention, whether it be placing a rod in a leg bone that's already fractured, near fracturing. Sometimes radiation can help. Try acupuncture or other supplements. Now, one of the drugs that we use for bone-related issues is bisphosphonates. Some of you may have heard of or received Zometa or Iridia, and these are important drugs when managing bone activity or bone events in myeloma. Now, if you have a new onset of bone pain or neuropathy, you really do need to talk with your provider. Sometimes a new bone fracture could be indication of recurrent disease, and so important for you to relay that information. So then moving on to slide 23, and this is my little buddy Duke. This is one of my grandpuppies, and I think he fully demonstrates how fatigued people can feel as they are experiencing myeloma and some of the treatment-related side effects. So moving on to slide 24 and going past little Duke, fatigue, depression, anxiety, this can all come from the diagnosis, from the treatment like steroids, and for people that maybe have already a baseline where they have some anxiety or they have some depression, it can be worsened going through this process. It can affect your quality of life, it can affect relationships, and there are sources to it, not just the diagnosis and the uncertainty in the treatment, but also anemia can add to fatigue. Maybe you need a transfusion. Pain adds to fatigue, as I was already talking about. So there needs to be a good balance between activity, because activity can improve fatigue, as well as getting proper rest, and good sleep hygiene is so important. I really strongly encourage people to be a part of a support group and a social network, and for those who need to, professional counseling. But I will tell you, I've had some of the most staunch people who finally came to my support group who say, I love coming to this group. It has helped me out the most. And so if you haven't tried it yet, I encourage you to try it. But if you're having symptoms of self-harm, really it's important for you to get help, and I strongly encourage it. And I want to just throw in a little comment that I received from a family member that some of the medications like Cymbalta, she experienced significant, or I apologize, maybe it was Lyrica, but if there's a medication that you're starting to take that gives you suicidal thought, take that seriously. Medications can cause that sensation as well. So seek help if you're feeling that. On slide 25, again, the IMF comes through for us with all of the tools that they have available on managing adverse events or side effects, understanding the medications you're taking, and little tip cards that are very helpful at better understanding the treatments and the side effects that you can experience along this journey. Dr. Faiman, can I ask that if you have any additional comments for that part of the information? I know you are well-versed in neuropathy and all of these side effects.
Right, and thank you so much for being so thorough in providing that overview. I think two key points with neuropathy I wanted to highlight. Number one is, just as you said, if you're having symptoms of numbness or tingling, then definitely report it as soon as possible, because there aren't any good known prevention. But there is a way that we can reverse that neuropathy in most cases. If we know about it, you can stop the medication or adjust the doses, but keeping you on treatment for a longer period of time to gain control of the myeloma. The second key point about neuropathy is there are a lot of different causes: uncontrolled diabetes, shingles, and nerve, tumors pressing on nerves. There's so many different causes, especially B vitamin deficiencies. And so if you're having these symptoms, please report it to your provider, and we can look into secondary causes. So I think that was the most important thing that I wanted to highlight before we go on to talk about clinical trials and other questions on slide number 26. And thank you for that great overview, Teresa. So when we talk about clinical trials, in the very beginning I suggested that each and every one of you that is a candidate for clinical trials should think about participating. We haven't gotten to where we are in 2015 with myeloma therapy without clinical trials. Gosh, in the mid-1990s when, Teresa and I started taking care of patients and their family members with myeloma, there wasn't much out there. So the next section is going to focus on the different clinical trials. What are they? How do you support the caregiver? What can I do to help myself? And what do I need to know about complementary and alternative medicine? Going on to slide 27 is just a brief overview of the clinical trials process. The International Myeloma Foundation has wonderful booklets on clinical trials and the different trials that are out there and the drugs that are approved. But just briefly, I wanted to highlight that you don't need to be in a last stage to participate. Years ago, the clinical trials were reserved for people that didn't have any other options. Nowadays, we have these new, great, and very effective drugs that are probably going to be better given early on in the disease. So please ask any of the questions that you can and try to go on the Myeloma Matrix. It has wonderful resource of all the clinical trials for multiple myeloma by phase. The earlier stage trials, phase 1 or phase 2, tend to be smaller with fewer centers, and everybody pretty much gets the same drug, or it's not randomized. The phase 3 tend to be the best evidence, and these are the trials that the FDA heavily thinks of when they're thinking of approving a drug for everybody to use. It compares the new drug to a standard of care therapy that tends to be larger. Again, there are so many different studies out there, and if you go to slide number 28, you can see by state how many open U.S. clinical trials are out there. So I mentioned the Myeloma Matrix on the myeloma.org website. However, clinicaltrials.gov is also another great resource, and the link is presented here in this presentation. You can see Texas has a whopping 81 studies open, but then little New York up here has 90 studies. So no matter where you are in the country, you should, however, have access to clinical trials. The next slide focuses on complementary and alternative medicine, and you'll see a picture here of Sandy Curtin. She's a dear colleague and a fellow nurse leadership board member of Teresa and I, and she did a wonderful review on complementary and alternative medicine. She's from Tucson, Arizona, and she's led courses on the different herbs that are out there and the things that you can do to keep you healthy using these types of methods. And so I would strongly encourage, if you have more questions, to follow this link on the slide, the myeloma.org link, and hear what she has to say. The key point to remember is that supplements can interact with your prescription medicines. For example, if you're on Velcade, green tea and vitamin C might simply interact with them. So discuss with your healthcare provider before starting any supplement. When you go to the next slide that's titled Tips on to Help Yourself, the question is, how can I help myself? How can I help others? The big deal is to be a consumer of healthcare and ask questions. I'm a very big proponent for my patients of getting a notepad and writing things down. Make a list on a piece of paper of all the questions you have. You might only have a short amount of time with your doctor or healthcare provider, and we want to make sure your questions are answered. If you have any questions at all about the care you're receiving or the advice that your healthcare providers are giving, seek an opinion of a myeloma specialist. I will say, though, too many cooks spoil the broth, and I say that because I have some people might want to go to 2, 3, 5, 10 different specialists, and you'll get 100 different opinions. So take it with a grain of salt. Try to learn all you can about that provider and take all the information in and take somebody with you. Also, it's important to help a primary care or healthcare provider. That will be your quarterback. You might go with the myeloma team and the cancer care team for most of your care, but it's important to keep that primary provider in your back pocket as somebody that can help you out. We mentioned steroids can cause high blood pressure and even diabetes. So that primary care provider can really help you get those other conditions under control to be as healthy as you can throughout the treatment. On slide 31, we talk about healthy lifestyle. Last year I did a piece on one of these Living Well series that was entitled Stopping to Breathe While Moving Forward. And it really highlighted the benefits of rest, relaxation, and nutrition. We think of a healthy lifestyle as somebody that has, quote-unquote, good nutrition. They tend to be more active. Again, we don't expect you to run a marathon, but setting the timer in your house to walk for 5 minutes at a time can really be beneficial. We also want you to try to promote your mental health. Teresa had mentioned the importance of joining a support group, and I think that that's really important. Finding people that you can communicate with in your religious community and your personal community as well. The next slide 33 discusses caring. The next slide 32 says you are not your cancer, and that is so true. Only you know what is important in your life. Make sure to discuss your priorities with the healthcare team. Many people are worried about asking if they can go on a trip to see their family members or go on a cruise, and you shouldn't be, because oftentimes if you're responding, we can take treatment holidays or breaks. We can plan an oral regimen instead of an IV if you have to go to work. We can take drug holidays, but we will discuss the trade-offs with you. The next slide is titled Caring for the Caregiver. This is slide 33. Think about the person, and Teresa shared some information early on about how long people are living with myeloma. Years ago, it used to be 2 to 3 years, but now it's often 5, 10 plus years. And that can be very stressful for the caregiver. So it's an important thing to remember that caregiving can be very stressful, and the caregiver needs to care for themselves as well. The regular health maintenance with mammograms and other screenings is really important so that they can stay healthy. There are some tips that are listed on this slide, and they're very important, I think. Accessing support groups, maintaining interest in friendships, and so on are really important. Taking time for medication and keeping a journal as well can be beneficial. The next few slides will provide for you some resources. It's really important to highlight this info line, I think. The 1-800-452-CURE hotline is available from 9 a.m. to 4 p.m. Pacific in the U.S. and Canada, and it's welcome to everybody. Also go to the myeloma.org website. There's numerous resources available. And finally, on slide number 35, when we're talking about resources as well, remember, myeloma is a very individual disease. Just because person A has myeloma does not mean they're going to behave the disease is going to behave the same way or they're going to have the same outcomes as person B. So it's important to remember that you're an individual. Discuss your side effects with your nurses and your healthcare team, and always try to be, confident in the treatment that you select. I think at this point now we would like to stop and thank you for your participation and maybe try to answer some of your unasked questions. Thank you.
Yeah, thank you, Beth. And some of those unasked questions, and we don't have to answer them here, but I think it's oftentimes important to look at, the questions that aren't being asked even in the doctor's office, things about sexuality, financial concerns, what are the resources, and, when the treatment is no longer working, what are the options for end of life? And so those are conversations that don't always happen, but we're available to answer those questions as well. So, LaPortia, if you're able to, we would love to take some questions. We probably have time for, 10 minutes worth of questions?
And your first question comes from the line of Linda Vollmer.
Yes. Is there any age limit for bone marrow transplant, and what is the criteria for that?
Great. And Beth, if you don't mind, I'll try and
take that one.
Question.
Sure.
I'll tell you that, and I apologize, I missed your first name, but I will share with the group that, as people get older, their organs get older, but we are living younger as a society. And so there isn't a specific age. It's more of a chronologic age, to be quite honest. We've had people as old as 78 go through the autologous stem cell transplant process, and very successfully. And there have been some 50-year-olds that we wouldn't allow to go through because of, lung function that's too compromised from years of smoking. And so that's where that living a healthy lifestyle, because you don't know what treatments are going to be in the future for you and possible for you. And so you want to keep all those options open. And so what is the criteria? It's, I think, fairly liberal. Basically, reasonable organ function as far as heart, lung, kidney, but people on dialysis can go through transplant very successfully. The more mobile a person is, the more active they're going to be and hopefully withstand side effects. So the criteria is fairly liberal, but would have to be an individual decision with that provider.
Teresa, if I just might add in, I think that's these are all very important points and totally correct. I think the important thing, though, too, is there needs to be a caregiver. So the individual that goes through transplant will need sometimes significant support. So a caregiver needs to be identified as well, and those, certain support needs to be in place before one proceeds with transplant.
And an absolutely important and excellent point. Thank you, Dr. Faiman.
You can call me Beth.
Okay.
Of course.
Other questions?
And your next question comes from the line of Rosemary Dahl.
Yes. My husband is on Zometa, has been on it for 12 months. And do they do any testing to see how well the drug is working on the lesions in the bone?
I can take this question, Teresa, if that's okay. So years ago, when we first started using Zometa, there were some bone tumor turnover markers, so blood tests that they would draw to see how much calcium was lost from the bone and such. And so we've really shied away from that. Basically, we want to decrease the future risk of fractures, and the lesions won't necessarily disappear and they won't go away, but they kind of get a little bit more covered over is a way I think of it. So we typically will x-ray bones to look for new lesions, and it's a different standard of care per your institution. Our rule is about every year, or if you have any new complaints, but again, it's very individualized. The take-home point is that as long as the myeloma is in good remission, you're less likely to have further damage to the bone. So I hope that helps answer your question a bit.
Yes, thank you very much.
My pleasure.
And your next question comes from the line of Thomas Tucker.
Yes, I just wanted to express my appreciation for some of the good information you provided. There's some of the graphics, like particularly that one about that had the IgA and lambda and all that would be useful to share with my support group. Is it possible to get copies of those that we could use?
I would be happy to provide that. I think you're able to download these slides as well. I don't have it copyrighted. It's something I just made up myself. And so, and Diane, if that's something that could be shared or another version that the IMF has available, but I'm more than happy to let you use that with your group.
Great. Well, it'd be easier to what's downloadable is a PDF file. It'd be great to have it as either a Word or a PowerPoint file.
Sure.
It is a PowerPoint, and I can sure let Diane have that, and Diane, you may know how that could be.
Yeah. If you would just follow up with the International Myeloma Foundation information line after the call. Again, that's 1-800-452-CURE. It's on the slides. We'll see what we can do to help you.
Thank you.
And your next question comes from the line of Sas Kazam.
I have a couple of questions. Slide 14 mentions day 100 plus for evaluation. Is that typically when response is first measured after stem cell transplant? And part 2 of the same question is, what's the frequency with which that response continues to be measured?
Okay, and I'm happy to start that answer, and Beth, if there are other things you want to contribute. You know, the time frame for when we reevaluate after transplant what the myeloma is doing is a little bit variable. In the transplant community, day 100, whether it be auto, allo, lymphoma, myeloma, it doesn't really matter. This is a fairly standard time point for a post-transplant evaluation. Having said that, I know that at Mayo Clinic in Rochester that we will do a free light chain evaluation prior to the patient returning home. So, you know, around day 20, we'll be doing that evaluation. We do that, but we really put more stock in what the results show at day 100. The other caveat that I will add to that is for our patients that we are looking at adding maintenance therapy, we will oftentimes have them come back prior to day 100 and reevaluate the myeloma at that point. Ongoing monitoring is a little bit based on what type of therapy, maintenance therapy or no therapy or consolidation that people are having and how their myeloma has responded to the previous therapy. Anything else you could add, Beth?
Yeah, I would totally agree with that statement. And if you think about it, you get a high dose of chemotherapy in somebody that's already been responding. So remember, we don't typically give autologous transplants to people that aren't responding to the treatment they're on. So the chance of you progressing within that first 100 days is pretty low. In my institution, we tend to check labs at the first about 6-week mark, and then at that day 100 evaluation is when we decide, like Teresa's center, I don't know if you've heard of the Mayo Clinic, they've done a few transplants in their day, but we tend to decide about maintenance after 3 months. That's where the day 100 is. So. And I think there was a second part of your question.
It was actually a second question, which was, my wife is getting a subcutaneous Velcade weekly, dexamethasone at this. She's going through Cyborg-D. She's in the 3rd month of it. So dexamethasone is now on a weekly basis, and she's getting cyclophosphamide as well weekly. She's finding in the evenings, typically when she goes to bed, muscle pain in her legs, and one leg or the other or both, which frankly just using some topical Voltaren has helped. Just wondering if you have any comment on that. She has no bone lesions or any other, frankly, any other effects at this point in time.
Yeah, so, and I can take that question, and thank you for bringing that up, because those, when you go to bed and you have those side effects, that we hear that very, very often, don't we, Teresa, that it's when you go to bed or you're not moving around, oftentimes it's like cramping. We have people take, tonic water, sometimes potassium and magnesium supplements you can discuss with your healthcare provider, and low doses of a medication called Neurontin or gabapentin. The Cyborg D tends to be very effective even at the weekly dosing of the Velcade, but make sure your healthcare provider knows, because this is a form of neuropathy. It can take very many different forms. Make sure it's not related to the Velcade. Check the disease status and make sure she's in remission, and they might be able to adjust the doses. But to answer what you can do, discuss the possibility of the tonic water and the different massaging the legs as well with the cocoa butter. Teresa had mentioned that on her slide as well. Massage can really help relieve the pain. That's something you can do, caregiver.
Sure. Ladies and gentlemen, at this time, I would like to sincerely thank our distinguished faculty, Dr. Beth Faiman and Teresa Miceli. I also would like to remind you that if your questions were unanswered or if you have any other questions in the future, please call the International Myeloma Foundation information line at 1-800-452-CURE. I would also like to invite you all to the next Living Well with Myeloma teleconference series, which will be Myeloma 101, Updates on Treatment and Pain Management by Dr. Brian Dorey, and that will be on November 19th. And once again, I'd like to thank you all for joining us, and once again thank our sponsors, Bristol Myers Squibb, Celgene Corporation, Millennium, the Takeda Oncology Company. Have a great evening.